Hey guys, welcome to this pharmacology drug class review on the antiplatelet agent, aspirin. In this session, I'm going to explain why aspirin matters and is clinically relevant in a manner that is easy to understand. Now, most people, in my personal opinion, take aspirin for granted. They assume they know everything about it. I know I did, but my experience is that most surprisingly don't really know the true mechanism and how that mechanism translates into meaningful evidence that supports its use. I don't say that without any disrespect to anybody, but I was shocked not only when I challenged myself, but when I started asking my colleagues around me. But no worries, guys. We're going to take care of that. We're going to fix that for all of us today, okay? I'm Dr. Busti, and thanks for joining me here on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the things that we do, include pharmacology and the drugs that we use every day. I believe that when we understand the why behind the decisions that we make, it becomes easier in how we manage patients. In my 30 years of experience, aspirin is one of those drugs that is a must-know treatment, regardless of where you practice, right? However, in my opinion and my experience, there's great confusion about its use for primary versus secondary prevention. I see it, unfortunately, done all the time incorrectly. And there's been huge trials, things like ISIS-2, that have set the stage for its use. We're going to make sense of all that, okay? Now, with all of our drug class reviews that I do, right, we cover core content. That core content includes the agents, which in this case is only one, aspirin, right? Indications, common uses, and sometimes things that we don't even think about, right? The net benefit, and then move into that pharmacology where it all starts to really come together and make sense of the clinical knowledge and application piece that we're going to dive into towards the end, and then we'll pull it all together. All right, so aspirin is our agent. That's straightforward. Many commonly, it's abbreviated ASA. But what about salicylic acid? I've seen that term used. Sometimes it seems like it's used interchangeably. Sometimes that creates a little bit of confusion. But aspirin and salicylic acid are technically not the same. Aspirin does get converted into salicylic acid. So let's just take a moment and look at that, okay? What I provided you here is a basic diagram showing the chemical reaction of the formulation. So here, aspirin is acetylsalicylic acid, ASA. Okay, that's that abbreviation. That acetyl group is added there, and that's, you can see that right here. It was added to the hydroxyl group of salicylic acid. So here's that hydroxyl group. But through a process of hydrolysis, okay, which rapidly occurs when we ingest the medication. Okay, this is one of the few medicines that really gets absorbed pretty quickly once you've taken it. It starts to break down into salicylic acid. So the salicylic acid is what goes into the body, and you get salicylate toxicity, right, from salicylic acid when you overdose or take too much aspirin, right? But why was it developed like this? Because this is, ASA, or acetyl salicylic acid, is a synthetic derivative of salicylic acid. Okay, well, it's done that in part because pure salicylic acid was very irritating to the gastrointestinal tract, was hard to tolerate. So we modified drugs in some ways like this to make them more palatable for administration, to improve bioavailability, to improve the tolerability, right? And in this case, it's almost like it's like a prodrug scenario, right? So it gets hydrolyzed, and then it gets formed into salicylic acid and this acetic acid, over there. But that's what happens when this drug is administered by mouth, okay? Which is the main formulation that we use. So I wanted to just kind of make sure that I address that piece. All right, now let's move to indications and uses. And this is where I'm going to break it down by acute versus chronic, and follow me here because it's important, because there's some unique indications that most drugs don't have, okay? All right, first being acute care, okay? The acute care scenario here is the analgesia, antipyretics, right? It's a fever reducer. Anti-inflammatory, we can use it for arthritis, even pericarditis. That's inflammation around the of the heart, the pericardial tissue, right? So the pericardium gets inflamed and irritated. And then, of course, vascular. That's what most people do. It's like we use it to prevent cardiovascular disease or events. Well, it's really secondary prevention. And that's one of those things I was talking about at the beginning where people get confused at primary before the event has happened, right? So secondary prevention is something's happened enough that we need to prevent it from happening again. That's secondary prevention. Most of the data and the support for aspirin use in cardiovascular related diseases is in secondary prevention. There's a lot of controversy surrounding primary prevention. There's a lot of people that just sort of go, well, if it helps over in secondary, gosh, it sort of makes sense that it would help in the primary, and that's not always the case. You expose people to drugs earlier in life, you increase the risk of side effects and risk of bleeding that don't outweigh the benefits, right? So that's not always the case, and that's one of those things that I think people get confused on, that just because someone has a risk factor, hypertension, or someone in the family had a heart attack, does not necessarily mean that you should start them on primary prevention for with aspirin therapy. But for those with vascular disease, we're talking about acute ischemic stroke, obviously not hemorrhagic strokes. TIA, right? Those are strokes or ischemic strokes that typically resolve in the first 24 hours, typically. Acute coronary syndrome, STEMI, NSTEMI, and of course unstable angina scenarios. Revascularization procedures, so they went into PCI, they got intervention, they get a stent placed, and they're now on dual antiplatelet drug therapies, and aspirin is clearly one of those. But then on the acute care, there's also pediatric Kawasaki's disease. This is a vasculitis, inflammation of the vessel wall. And you may go, whoa, 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 whoa. I thought we weren't, and you're going to hear me talk about this a little bit later. We're not supposed to use aspirin in pediatric patients because of the risk of Reye syndrome. Well, that's true. But you have to weigh the risk and the benefits of the scenario that you're dealing with. And so one of the indications is Kawasaki's disease, and actually really high doses compared to what you would normally think of, okay? So that's a unique indication that's important for you to remember. As it relates to chronic, people can use it for analgesia, they can use it for inflammation, arthritis, and things like that. Secondary prevention of cardiovascular disease, that's where the ISIS-2 trial was. That's huge study, okay? That solidified its use in the secondary prevention in cardiovascular disease, primarily STEMI patients, but also some NSTEMI patients, right, given in that first 24 hours and continued for beyond 30 days. Secondary prevention of ischemic stroke, TIA, ischemic heart disease, pregnancy, preterm or preeclampsia prevention in high-risk women. That's another one of those unique indications. And then lastly are topical formulations, right? Salicylic acid for warts, acne, even chemical peels. It facilitates the exfoliation of the skin that unclogs pores and other things like that. Okay, let's now move to the net benefit of the drug, especially in the context when we have other antiplatelet drugs categories and options out there. So overall, the history of aspirin is extensive. It's kind of like warfarin. It's been around for a long time. That gives us a lot of experience. We recognize its pros, cons, limitations, issues, and we feel comfortable with those, right? I mean, some of these drugs came, like a drug like this came on the market today. We learned all this in toxicology. I mean, there's some interesting toxicology going on if you overdose on this. I don't know. I mean, I think clinicians would be very concerned. I don't even know if it'd get approved, right? So these are the weird scenarios about older drugs that have finally been accepted, and we know their issues, and we feel just comfortable with them, right? But as it relates to the net benefit, not only the mechanism, which we're going to see here is an irreversible inhibitor, selective at low doses especially, for COX-1 in the platelet. That's important for arterial vascular disease where the inflammation can stimulate platelet activation that leads to platelet aggregation that forms an arterial thrombosis, which is primarily made up of platelets. Yes, there's fibrin in there. Yes, there's some red blood cells in there, but it's primarily made up of platelets. Now, as it relates to arterial vascular disease, whether it's ischemic cerebrovascular accident, stroke, right? Ischemic stroke, whether it's TIA, whether it's PVD, PAD, or coronary artery disease, there are studies out there that show the value in secondary prevention. Again, that preventing the second time something's going to happen. And specifically, the ICES TRUE was a huge randomized controlled trial. So it was good quality with good internal validity for addressing this question. Now, it was also a streptokinase study. There were 4 groups, right? Patients got on aspirin, aspirin plus placebo, aspirin plus streptokinase by itself, right? And this was the big study that really showed that this drug reduces vascular related mortality by about 22% at 30 days. That's huge, okay? And that's primarily why we use it. It doesn't reduce all-cause mortality, so don't say that. It's vascular-related mortality, because that's in part some of the endpoints that the study looked at, okay? So this drug is cheap. It's available over the counter. It has good mechanism of action in the context for these conditions that require some protection, and we have evidence to support its use, okay? Now, let's move into the pharmacology, which will start to make sense of why it works as an antipyretic, why it works as an anti-inflammatory agent, why it has antiplatelet properties and prevents the aggregation, okay? But also why it can worsen asthma in certain patients with Samter's triad, right? So what I've put together for you here is a diagram of the mechanism of reaction that's happening when arachidonic acid gets released from the cell membranes. Now, arachidonic acid is an omega-6 fatty acid. Phospholipase A2 is the enzyme that facilitates that release. Now, in this diagram that I've given you, I show you what happens to arachidonic acid, but I also show you the various drugs that are been developed over the decades to try to interfere with this process, mainly for inflammation, right? So a lot of these drugs are anti-inflammatory agents. The exception down here is misoprostol, which is trying to stimulate, trying to act like prostaglandins, mainly to protect from GI bleeds in patients on NSAIDs, right? But the rest of all these are anti-inflammatory drugs, antipyretic drugs, things that we're going to do to reduce inflammation. The thromboxane A2 over here is the big one as it relates to the contributors to platelets becoming activated, okay, which we'll come to in a second. But just follow me for a moment. So arachidonic acid gets released from the cell membrane. It has one of 2 pathways that it can go down. It can go down the 5-lipoxygenase pathway and form leukotrienes, which are other pro-inflammatory mediators, okay? Or it can go down the cyclooxygenase pathway. And within cyclooxygenase, there are different subtypes. We most commonly think of COX-1 and COX-2. COX-2 tends to be expressed in areas that are typically more inflammation. COX-1 is more constitutively in a lot of different places, and our platelets really only express COX-1. So if we want a drug that's going to impact platelet activation, aggregation, we want a drug that's going to work predominantly on COX-1, and at lower doses, that's what aspirin does. Now you see NSAIDs, COX-2 inhibitors, steroids, all of those things can impact COX as well. And they do it at different degrees of COX-1 to COX-2 ratios, right? Now you see steroids, and when I say steroids, I'm talking about corticosteroids or glucocorticoids, those kind of drugs. Things like dexamethasone, prednisone, methylprednisolone, those hydrocortisone. Those drugs that are affecting the genes that make those enzymes, okay? They affect the gene expression of those. Whereas NSAIDs, COX-2 inhibitors, aspirin, those things are working on on the actual enzyme itself. And so when you see aspirin here, it's different than a NSAID and COX-2 inhibitor by mechanism, okay, as well. But this is where if arachidonic acid goes down the cyclooxygenase pathway, it forms prostaglandins. And prostaglandins have a lot of important physiologic features. One is regulation of the blood vessel size or diameter and the flow to tissue. So prostacyclin in particular, PGI, is known to be vasodilatory. So when I give a drug like aspirin or NSAIDs, I can cause vascular constriction to certain blood vessels and certain tissues, including the GI tract, which is not the only reason, one reason why these drugs can cause or increase the risk of gastric irritation, erosion, and eventually ulcers, because we decrease the perfusion to that tissue that keep it healthy and growing and protected, right? Prostaglandins influence the mediation of bicarb and other things in the GI tract, but also influences the flow through the renal, afferent, arterial, and the kidneys. We can reduce them. So NSAIDs can sometimes worsen blood pressure, fluid volume because of that, because anytime we reduce the perfusion through the kidney, especially in the renal afferent, the juxtacular glomerular cells at that nephron are going to get, and the glomerulus are going to get turned on and release renin. Well, the end product of renin is aldosterone. And aldosterone goes to the kidney and facilitates sodium water reabsorption, which increases plasma volume, which increases our blood pressure. So that's why NSAIDs are not always great, okay? But here's the big difference in mechanism between NSAIDs and aspirin. Aspirin is an irreversible inhibitor of COX, and especially of COX-1 and that platelet. So for the life of that platelet and that enzyme, it's out. This is one of the reasons why when you take aspirin, maybe the drug left the body, you metabolize it, it's gone, but the biologic effect is still lingering. So that's why patients who are on aspirin have to stop their aspirin upwards of 7 days. Why? Because a platelet has a lifespan of 7 to 10 days. So you have to wait for new platelets to get formed with new COX enzyme that won't be inhibited by aspirin that has been stopped. So that by the time you go into surgery, you're not just going to have increased risk of bleeding, you have functional platelets. NSAIDs are competitive. They're not irreversible. They're competitive inhibitors of cyclooxygenase, so they come on and off that inhibition. And so they're not reliable and protective against those platelets that are getting activated and aggregating in an arterial thrombotic episode, such as an acute coronary syndrome or an ischemic stroke scenario. Okay? So that's why they actually worsen outcomes, because they only increase plasma volume and raise blood pressure, but they also don't have the antiplatelet effects that are necessary. Well, where do the antiplatelet effects occur predominantly? Well, it's down here in this thromboxane A2. If we block COX, we block this prostaglandins, we then don't make thromboxane A2, right? So that's the antiplatelet sort of effect, and it's an irreversible effect on the cyclooxygenase, specifically cyclooxygenase 1 in that platelet. Now this is looking at all of the various activators of a platelet, okay? Things that will turn on and stimulate the platelet, and what the end result of that platelet activation is an upregulation of glycoprotein 2B 3A receptors. Those receptors on the surface of the platelet are very important to aggregating and connecting with other platelets through the same receptor. And it's typically fibrin monomers that are connecting those things and orchestrating that. Well, where does fibrin come from? Coagulation cascade. Remember, prothrombin gets converted to thrombin. Thrombin then converts fibrinogen to fibrin. And fibrin monomers get used to solidify the thrombus that it's forming, okay? So there are platelets there are red blood cells there, there's clotting factors, all these things that are there, and so we're impacting them. That's why patients with acute coronary syndrome and STEMI, we give them many times anticoagulants like heparin or low molecular weight heparin, plus aspirin, and sometimes even a third agent, clopidogrel, or some P2Y12 receptor inhibitor, or ADP inhibitor. That's over here. Right? So you see we have thromboxane, we have thrombin from the coagulation cascade, serotonin, epinephrine, collagen exposure, usually from a damaged blood vessel. All of those things can turn on and activate a platelet. Now, why are those arrows all different thicknesses? Because that corresponds to the degree of influence or degree of activation, how stimulating they can be at activating the platelet. Right? So they're not all equal activators. But this ADP that we're talking about over here, this is involving the P2Y12 receptors. And we have drugs that inhibit that, right? Those are our P2Y12 inhibitors. Right? So here's aspirin over here. This is where Plavix and Prasugrel, Ticagrelor, those drugs are working. And then, of course, here's where our aspirin is working as well. Now, NSAIDs will work on thromboxane too. It's just not going to be the same level of protection. And when we say aspirin here, we're really talking about, remember, it gets metabolized over to salicylic acid. But we just use this for simplicity. Putting this in the context of coagulation with platelet activation aggregation, right? So all of this information over here is, this direction is the coagulation cascade, both the extrinsic and intrinsic pathways that form that fibrin, okay? Here's your clot down here, your thrombus, and then over here is our platelet. Again, all these, and I didn't list them all the various activators, triggers, that would turn on platelet aggregation, all right? Upregulate those receptors that allow the platelets to start binding to each other with the fibrin, and they facilitate also the formation of a clot. And so that's where aspirin works. So aspirin can protect against venous thromboembolic events as well as arterial thromboembolic. They just work better. It works better, and other antiplatelet drugs work better on arterial formed clots because they're primarily made up of platelets for that reason. Okay? Now, what about the duration of effect? If I have an irreversible inhibition of that enzyme, then I said earlier that for the life of that enzyme, wherever that enzyme is located, it's out until new enzyme is re-expressed and made. Or, like in the platelet scenario, new platelets have to be made that have enzymes that are present in there that are not being inhibited by aspirin. Now, this is a dose concentration dependent effect. So at lower doses, we get more preferential focus mainly on COX-1, and platelets only express COX-1. And so we get strong antiplatelet effect even at lower doses. Now, we might bolus the patient or give them a higher dose up front, like commonly people give 324, 325 milligrams of aspirin followed by 81 milligrams a day thereafter. And the reason they're using that 81 milligrams is in part due to that dose concentration dependent influence on COX-1 and COX-2. But for the life of that platelet, it's out. And remember, the platelets have a half-life or a lifespan of about 7 to 10 days. And so that's why we have to stop aspirin 1 week before surgery, is that in reason. So I try to summarize here for you that low doses, typically between 81 and 325, they're focusing mainly on COX-1, specifically in those platelets. When you start exceeding the 325, then you get some loss of selectivity, and only really at that point, yes, you'll get COX-2. This is where your anti-inflammatory properties for analgesia and things like that are really probably going to come in. But you're also increasing the concentrations of salicylic acid in the body, okay? So that's where salicylate toxicities can start to develop with people taking repeated doses that are too high. No different than the same thing with acetaminophen can happen, right? So this irreversible binding to the enzyme produces a long biologic effect wherever that enzyme is being inhibited. Okay, so now let's move into clinical knowledge. Okay? This is that application piece where we take things I've been talking about and really start to continue to fine-tune it, and I give you just some nuances related to clinical practice. So the first thing is atherosclerotic cardiovascular disease, ASCVD. Okay? You're going to see that term a lot. You read other guidelines and other things like that. It's huge, right? Aspirin is primarily established for secondary, not primary prevention. And that's based off evidence. The guidelines have debated this. There's discussion about it. There's these conversations about having a conversation with your patient about the pros and the cons, so shared decision making. Not opposed to that, as long as the proper context is given to the patient so they can make an educated decision. Don't extrapolate ISIS-2 to a primary prevention standpoint. That is not where the evidence is in that particular trial, right? So it may make sense to you, but again, you're weighing the risk versus benefit and starting people on early in life on aspirin just because they have a risk factor for something, right? So there's a lot of controversy around that, and it may be actually harmful to the patient. What about acute ischemic strokes? Well, patients who have received thrombolytic therapy, because remember, if they come in with acute ischemic stroke and they're within that 4.5 hour window from the time of last being normal, and assuming they don't have any contraindications, which I'm not going to go through right now, and they received thrombolytic therapy like TPA or tenecteplase, then it is recommended to consider avoiding this aspirin for the first 24 hours after the administration, simply because we don't want to increase the risk of a hemorrhagic conversion. I mean, unfortunately, just having an acute ischemic stroke by itself can cause a spontaneous hemorrhagic conversion because the tissue is just frail, especially with a large ischemic stroke. The other is that obviously you're mixing it, you have that risk, but you add a thrombolytic to it, like alteplase or tenecteplase, and that obviously increases the risk of bleeding, right? So we need things to calm down, let the tissue kind of be less inflamed and irritated, right? And so we wait 24 hours for that reason. From a dosing standpoint, again, we talked a little bit about the standard doses that we would use in acute versus chronic. So in the acute, we sometimes will bolus people, give them a loading dose up to that 325. Again, remember that seems to be the threshold where that selectivity, where other things can be, side effects can occur, right? So we give them that first dose up there, and then we start about an 81 milligrams a day, most commonly for secondary prevention. But look at the dose for Kawasaki's disease in those pediatric patients if you qualify. These are typically kids with coronary aneurysms as a result of the vasculitis itself. I mean, 80 to 100 milligrams per kilogram in 4 divided doses, along with IVIG therapies. Now again, this is more of a life-threatening vasculitis, especially if it's involving the coronary arteries, which typically is identified on ultrasound in these patients. So it's a difficult decision to make, and yes, there's this risk of Reye syndrome, but again, there's also complications if you don't treat this vasculitis. So it's one of those unique scenarios, and of course we talked about preeclampsia in high-risk patients as well. What about enteric versus non-enteric formulations? Make sure that if you're going to administer this in the acute, where you tell patients to take 162 to 324 milligrams, basically 4 baby aspirins or the 81s, that's non-enteric coated, because trying to chew and bite on an enteric, that's hard. Ironically, in the ISIS-2 trial, they did use that. I think that was a little weird. I don't recommend that. So I use non-enteric formulations in the acute, and then of course the enteric coated formulations in the secondary long-term kind of prevention. There is a formulation with aspirin and extended release dipyridamole. This is used and mainly indicated only for patients with stroke, not secondary prevention of coronary artery disease or a cardiac event. Patients who cannot tolerate oral administration, suppositories is another option. And just like with NSAIDs, we want patients to take it with food to try to reduce the topical gastritis. Again, remember that acetylsalicylic acid gets converted by hydrolysis pretty rapidly. And so you get some absorption within the first 20 minutes of administering, especially if you chew it up in a non-enteric coated formulation. But we don't want to cause that topical gastritis that can make people nauseous, okay? Now, what would be contraindications of using aspirin? Well, it's not rocket science. If they're actively bleeding, that's not a great idea, especially for a drug that has an irreversible inhibition of platelet COX-1. That's not a good idea. Hypersensitivity, NSAIDs, maybe be careful, right? Patients with Samter's triad, what is that? Well, patients who have asthma, nasal polyps, and allergies. That triad sets them up for increased, basically, leukotrienes that exacerbate their underlying hyperactive airway disease. Now, why might that occur? Well, Samter's triad will cause that arachidonic acid that would normally go down the cyclooxidase pathway to move back the other direction and basically increase the pathway towards leukotriene production. And that leukotriene is a pro-inflammatory cytokine. And that's why if you look over there, the drugs on that diagram are xyleutin and montelukast and drugs like that, which we use in patients with asthma to try to prevent that from happening. Now, we talked about a little bit of the risk of GI gastritis, and we want patients to take it with food and all this business, just like NSAIDs. And the higher the dose, the more COX-2 you're going to inhibit, which also can impact other areas of the body. So COX-1, COX-2, we're changing prostaglandins, we change blood flow to the GI tract, we're decreasing prostaglandin-mediated bicarb production, mucus production. You create the perfect environment or milieu that sets these patients up for a higher risk of bleeding, right? So that's why we want to use the lower effective doses as much as possible, why we want to consider even enteric-coated to facilitate some less topical gastritis. It still gets in the body, still can affect prostaglandins and still affect blood flow. But patients who are older, patients who are smokers, patients who have H. pylori who are already at risk for peptic ulcer disease, patients using higher doses or also concomitant NSAIDs, right? So you're on aspirin plus something else. That's where the risk really starts to go up. And we saw this with the COX-2 inhibitors, which were not cardioprotective. Remember, because platelets only express COX-1, so COX-2 inhibitors are not going to be very helpful. But we saw them because patients were supposed to take aspirin plus the COX-2 inhibitor. Well, that just ruined the GI protective benefits of the COX-2 inhibitors. You lost it. Patients on steroids, because again, they're affecting arachidonic acid production. They're affecting prostaglandins. We see that antiplatelet drugs, other drugs like clopidogrel, prasugrel, ticagrelor, right? Because patients are on dual antiplatelet therapy now for not only stents post-procedures, right, for 12 months, but even also acute ischemic strokes, right? We're seeing dual antiplatelet therapies. This is talking about the Samter's triad. Again, I think really what I wanted to show you here is that the arachidonic acid it can't go this way. This way is blocked with aspirin. Because remember, it's an irreversible inhibitor. So that pathway is shut down, and so what ends up happening is it gets shunted down this pathway and forms these. And that's why we have all these drugs over here that interfere with that process and are used in patients with asthma or hyperactive airway disease to shut down those allergy or pro-inflammatory mediators that basically exacerbate the airway. Now, what about salicylate toxicity? Okay, this is a big deal. I mentioned it earlier, like, man, the toxicology of this drug at higher doses it's interesting. I mean, it's got really cool biochemistry and its pathology explanation. I don't have time to go into all that here, but just trust me that when this happens, these patients are very sick, and they do carry a high mortality if this is not treated appropriately and aggressively, right? So the dose or diagnosis occurs when the salicylate levels get greater than 20. These patients end up going into a metabolic acidosis. So they have an anion gap metabolic acidosis. They develop a hyperthermia. They start having altered mental status. There's a few things that you can do to help them, but they go through these various phases. Phase one being that they start to have an increased respiratory drive. Remember, this is an acid in their body. And so the respiratory center starts to increase their respiratory drive. They blow off CO2. Well, if you blow off CO2, you're going to facilitate hyperventilation, tachypnea. That puts people into a respiratory alkalosis initially. That is then followed by a metabolic acidosis. Okay, so they get a mixed acid-base disturbance. And then over time, what happens is because of the acidosis, these patients start shifting potassium in exchange for hydrogen ions, and they start losing bicarb, concentrations start going down, and then they start losing the potassium from sources, and they develop cerebral edema and go into non-cardiogenic pulmonary edema and cerebral edema, and that's where the altered mental status occurs. Well, in patients with Reye syndrome, these are pediatric patients, right? Sorry, let me go back for 1 second. I just want to make one comment about the salicylates. So one way you treat this is you could give them sodium bicarb and try to alkalize the urine to trap the acid in the urine and excrete it. That is a strategy. But really, these patients need dialysis more urgently if you can, to get it off. All right, Reye syndrome. I talked about it earlier in the context of patients with Kawasaki's disease or at risk for it, especially if they develop it and they get the vasculitis and we start them on high dose. So remember, we don't typically like to use aspirin as an antipyretic or anti-inflammatory agent in patients with viral syndromes, especially pediatric patients, because of the risk of this. Well, what is this? Well, unfortunately, it's a kind of a delayed, prolonged, kind of miserable death. They've developed these fatty infiltrations of the liver itself, and that actually disrupts the ability of fatty acids to be oxidized, and that facilitates abnormal metabolism that leads to encephalopathy, brain swelling, and then they start vomiting like profusely. So they have fluid electrolyte abnormalities, glucose homeostasis abnormalities, and again, they die about 3 to 5 days after that effect, okay? Now, there's a couple issues related to storage and handling of these medications. One is hydrolysis, it changes the medication, right? And acetylsalicylic acid gets converted to salicylic acid. So moisture in the air causes that salicylate to occur, and it gives it a vinegar-like smell or taste, right? So we need to counsel patients to avoid aspirin if it already smells or has a little bit of that effect. Pediatric patients, yes, we want to be careful with their use and the risk of Reye syndrome, but we have to weigh that in the indication. So as long as it's considered Kawasaki's and you meet the criteria, typically, again, they have coronary lesions on ultrasound, then we can consider it, but we probably should counsel, obviously, the patient and their patient's family. All right, what about pregnancy? So while aspirin is not FDA approved for preeclampsia prevention, it is recommended in those high-risk patients with 2 moderate risk factors or at least 1 risk factor, high risk factor. It's ideally to start around that 12 to 16 weeks of gestation, okay? And those doses are around 81 to 162 milligrams until they actually deliver. Moving on to the other side of the spectrum of our geriatric patients, right? Remember, geriatric patients are on a lot more medications, higher risk for side effects, bleeding risks. They have poor renal function. They have a lot of other medications that affect their blood pressure and things like that. All these things can weigh in to inappropriate drug use in this patient population. Aspirin is not devoid of its problems in this, so we do want to weigh the risk versus benefit in this patient population as well, especially if they're on other anticoagulants or other antiplatelet drugs, or they suffer from chronic pain syndromes and have been historically on NSAID or COX-2-based therapy. Okay, guys, let's now move into summarizing and pulling this all together. Aspirin, remember, gets converted to salicylic acid. That's what's active in the body predominantly, okay? We use it for analgesia. We use it for inflammation. We use it for fevers. We also obviously use it for secondary prevention of vascular-related disease, including ischemic strokes, TIAs, and in patients with ischemic heart disease. Mechanism, very unique. It's an irreversible inhibitor of cyclooxygenase, and it's a dose-dependent influence on whether it's COX-1 and COX-2, amount of its inhibition. Remember, in a platelet, it's predominantly working on what does a platelet only express? COX-1. And that impacts the thromboxane A2 and prostaglandins in the local area. And it works for the life of that enzyme. So those platelets have to regenerate in order to make more COX-1. Obviously, just like NSAIDs, it can cause GI upset. We want to take it with food. We want to be careful and risk factors that increase the risk of GI bleed, things like their age, other drugs, comorbidities, also H. pylori and smoking. All of those things seem to create the perfect milieu for more gastric irritation. Take-home point, avoid in primary prevention unless the patient really feels like they want to do that, and then you have to do shared decision making. In pediatric patients, Kawasaki's disease, high dose, yes, the risk of Reye syndrome is there, but you got to weigh the risk versus the benefit. And then don't forget about your preeclampsia patients, another unique indication. And so these things can be really important, especially counsel patients not to overdose, not obviously intentionally, but even sometimes accidentally, because they can develop chronic salicylate toxicity and lead to acid-base disturbances. Okay, guys, I hope you found this information to be helpful, relevant. Please, again, subscribe to our channel on YouTube. Give us a like, share this with others, drop a comment, share an experience, anything like that. We would really appreciate that. And I really appreciate you taking the time to join me on this and learn and expand your knowledge. We all learn from each other. And so investment in that is always a good thing. Never stop learning the why, because it makes the how and managing patients much easier. Take care, guys.